Welcome everyone to today's webcast entitled Translating the Evidence on Individual Placement and Support into Practice, Application with Spinal Cord Injury. I am Cindy Kai from the American Institute for Research, or AIR, who led the development of the webcast. We're so very excited to have a panel of speakers with deep knowledge and practical expertise on individual placement and support, and its application to support the employment of individuals with disabilities, especially with spinal cord injury. The webcast is offered through the Center on Knowledge Translation for Disability and Rehabilitation Research, or KTDRR, funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDLR. I want to thank Rebecca Gaines from AIR, who was instrumental in developing today's webcast, and Ann Outlaw for her kind technical support. We have information that accompanies today's webcast on our website. This includes a PowerPoint file and a text description of the training materials. Please remember that these materials are copyrighted, and you must contact our presenters to ask permission to use any of the information. In today's webcast, our presenters will review the research on the use of IPS with individuals with spinal cord injury, evaluate the unique aspects of applying the IPS model with individuals with spinal cord injury, and discuss guidelines for successful implementation of IPS in SCI settings. Now, I'm going to turn to our presenters who will introduce themselves before they begin today's presentation. Lisa, would you please take away?
Hello, my name is Lisa Adamanelli. I'm a clinical psychologist and associate professor at the University of South Florida and at the Veterans Affairs Center of Innovation on Disability and Rehabilitation Research at CINDR, as it's known, at the James A. Haley Veterans Hospital. I'll let Sean and Jenny introduce themselves now as well.
My name is Sean Smith. I'm the SCI Vocational Counselor at the Department of Veteran Affairs, the Mikey DeBakey VA Medical Center. I'm a certified rehabilitation counselor and also an assistive technology professional.
And I am Jenny Kelleher. I am an implementation coordinator with the Research and Development Service at the Tuscaloosa VA Medical Center.
I want to start by thanking our hosts. Thank you, Cindy, for the kind introduction and for certainly inviting us to be part of this important webcast series. We're delighted to be here and share the work that we've done on the individual placement and support model in the area of spinal cord injury in the Veterans Healthcare Administration. In the first half of the presentation, or I should say third, I'm going to be talking about the research on using the IPS model in the VA system with our veterans with spinal cord injury. First, I'm going to start by offering an introduction to spinal cord injury, as there may be some people who are not familiar with working with individuals with SCI. And then the remainder of my portion of the presentation will discuss the employment outcomes that we had applying the IPS model in the Veterans Healthcare Administration with our veterans with SCI. So, to begin with, in terms of an overview of spinal cord injury, spinal cord injury disrupts movement, sensation, and autonomic nervous system function. The effects of spinal cord injury are many and varied. First of all, there's altered reflexes, impaired breathing, bowel and bladder impairments, loss of pain, muscle paralysis, which is the obvious thing that most people think of involving spinal cord injury, and loss of temperature and/or sensation or touch. When we talk about spinal cord injury, we need to keep in mind the various factors that affect the extent of the disability. In way of an example, I've listed some here. Of course, first and foremost would be the level and severity of the injury. That involves the specific nerve fibers that are injured, but there are also many associated complications with spinal cord injury: pain, spasticity, and contractures, to name a few. Musculoskeletal injury may be present at the time the spinal cord injury was sustained, and there might be pre-existing conditions such as cardiac disease. And then we also need to keep in mind patient factors. These involve things like motivation, age, and resources. When we talk about spinal cord injury, we describe the injury in terms of the level of injury and the completeness of the injury. To begin with, there are two levels of spinal cord injury: tetraplegia, what was formerly called quadriplegia, and paraplegia. Tetraplegia involves impairment or loss of motor and/or sensory function in all four extremities. The diagram on the right shows cervical level injuries in the first two figures, and so essentially this is where people usually describe that things are altered from the neck down, if you will. In paraplegia, there's impairment or loss of motor and/or sensory function in the chest, abdomen, and/or lower extremities. So you can see on the third figure in the right, a thoracic level injury would have impairment in the chest region and below, and a lower level lumbar injury would have impairment lower down the legs. We also talk about the completeness of the injury. A complete injury is one where there is no motor or sensory function below the level of injury, whereas an incomplete injury means there's partial motor and/or sensory function below the level of injury. So someone with a complete injury who has a high-level injury might be using, for example, a power wheelchair, whereas if someone has an incomplete injury, depending on their overall health status and perhaps their age, they may be even able to ambulate or certainly use a manual wheelchair. In spinal cord rehabilitation, there are three broad goals. The first is to prevent secondary complications. Next, we want to maximize physical functioning. And finally, focus on reintegration into the community. And certainly, going back to work falls into the category of full reintegration into the community. To accomplish these goals, the healthcare team works in an interdisciplinary fashion, and care is offered using a patient-centered model. You'll hear some illustrations of this from our next speaker, Sean. I'm going to shift now and talk about employment in spinal cord injury. Most people with spinal cord injury want to return to work. Unfortunately, the rates of employment following injury have been quite low, and depending on the study that you look at and the way that employment was defined, the specific statistics may vary, but they usually hover around 35% of people with spinal cord injury return to work after injury. Cross-sectional studies that ask how many people are working at the current time find that about 10% are working at the time of the particular survey. When we did a kickoff meeting for starting this initiative that I'll describe in the next part of the presentation, John Bollinger, who was the former Deputy Executive Director of Paralyzed Veterans of America, a veterans service organization, offered this quote to describe the problem. We have seen incredible changes over the years in restoration of function, advancement in the possibility of finding a cure, improvements in assistive technology, the ADA, civil rights, housing, and transportation. It's ironic that after all these years and all this hard work, here we are today with the same dismal unemployment rate we had among vets with SCI that we had 20 to 30 years ago. Part of the problem is that there has not been much guidance for the field on what an effective intervention for returning someone with a spinal cord injury to work is. Two recent systematic reviews found there was a profound lack of evidence in terms of interventional studies on employment in spinal cord injury. They cited that the strongest evidence for an effective vocational intervention is the randomized controlled trial on individual placement and supported employment, which was done in the VA and we'll describe in the latter half of my portion of this presentation. Before we move to the details of that study and the one that followed, let me give just a brief moment to talk about the emergence of the evidence-based practice of IPS. Supported employment is a term that has been used since the 1980s. It emerged as an intervention primarily for people with serious mental illness and developmental disabilities, generally used as a federal term to refer to general job supports. Individual placement and support over the next 2 decades evolved as the most standardized and well-researched approach to supported employment, specifically for persons with serious mental illness. SAMHSA describes it as an evidence-based practice with multiple service components. Based on that body of evidence, in 2003, there was a national implementation in the Veterans Healthcare Administration to roll out IPS for veterans who had mental disabilities, specifically psychotic illnesses or serious mental illness. In 2010, the Spinal Cord Injury Vocational Integration Study, or SCI-VIP, was funded. This was the first controlled study of vocational interventions in a spinal cord injury population. It was specifically the first study of IPS in a population of persons with a primary physical disability. The study tested whether IPS is better than the usual vocational approach for improving employment in SCI. Let me talk a little bit about the usual vocational approach or conventional treatment versus IPS, because introduction of this model really involved testing a paradigm shift in SCI rehabilitation. In the conventional approach to vocational rehabilitation in spinal cord injury, referrals were made for vocational rehabilitation after the conclusion of the spinal cord injury rehabilitation episode of care. Essentially, patients were referred after discharge from the Spinal Cord Injury Center to VR. The problem was there was very little or no connection with the treatment team, the healthcare team, that was helping the person with spinal cord injury manage their spinal cord injury. In the conventional way of handling VR, it was usually a stepwise approach for persons with SCI that involved independent living, skills training, pre-vocational training, or transitional employment, for example. By introducing the IPS model, we introduced a model where employment services were delivered as part of spinal cord injury rehabilitation care. This was an integrated model of treatment where services were delivered concurrently rather than sequentially. It also used rapid engagement in finding competitive employment using services such as job development and community-based services. So this was essentially a new way of treating vocational issues in the field of spinal cord injury, and we wanted to see whether it worked. We used the foundational principles of the IPS model from the SMI population. There are 8 principles. I won't go through all of them here because you'll hear them expanded in the next 2 presentations. I've highlighted a few already, but let me also point out that we certainly followed the principle of zero exclusion, which meant that any veteran with a spinal cord injury who desired work, regardless of their level of spinal cord injury or impairment, was eligible for services. Additionally, we referred our veterans for benefits counseling so they would understand the impact of work on their finances, and follow along support to help people maintain jobs after obtaining them was also included as part of the application of IPS in the SCI intervention. Let me talk a little bit about the methods of the study. This was a randomized controlled trial that was conducted at 6 VA spinal cord injury centers in the U.S. To be eligible, the veteran needed to be unemployed, working age, want to work, and live within proximity of the VA, which we defined as a 100-mile radius. 201 veterans with spinal cord injury participated in the study. 81 of them were randomized to IPS, and 76 were randomized to conventional vocational rehabilitation. We also had 44 who participated in observational-only sites where the IPS model was not introduced at the center. We refer to those individuals as observational participants. And we followed everyone for 12 months. This slide shows the results of the study in terms of the veterans obtaining a paying job by percentage. As you can see, veterans who received IPS were significantly more likely to obtain a paying job than those who received conventional vocational rehabilitation. In fact, those who received IPS had an employment rate of 25.9%. Those who were randomized to conventional vocational rehabilitation at the interventional sites had an employment rate of 10.5%, and those who were followed at observation-only sites had an employment rate of 2.3%. So IPS was significantly more likely to result in competitive employment than conventional vocational rehabilitation. The lessons we learned from this study were many. First and foremost, we learned that employment was treatable in the context of medical rehabilitation care, and IPS does in fact work for persons with chronic illness and disability. Some of the keys to success were awareness of employment as a viable goal for persons with spinal cord injury, having clinical champions on the treatment team who could act as resources for the vocational provider and the veteran, and providing care in a team-based integrated fashion. Both Sean and Jenny will expand on these keys in their sections of the presentation. I'm going to move ahead now and talk about our follow-up study, which was the predictive model over time to employment. This was a longitudinal study of employment outcomes. There were three primary aims of this study. First, increase the employment rate. Second, improve IPS program implementation. And third, determine the impact on health care utilization. The third aim is beyond the scope of this webcast, but you'll hear more about the employment rate in my presentation, and in Jenny's presentation she will talk about program implementation. Briefly, the methods of this study was a longitudinal single-arm mixed method study conducted at 7 centers. The eligibility criteria were essentially the same. We had over 1,000 veteran participants who participated in baseline interviews. Of those, 279 were enrolled in IPS. 66 of them were actually from the first SCI-VIP study. And there was a 24-month follow-up period. I want to point out a few notable characteristics of our IPS participants in this study. We enrolled people in IPS both as outpatients and people who were inpatients. In fact, almost 25% of our IPS participants were in the hospital receiving inpatient care when they enrolled. Certainly their ability to find and participate in work may have been limited by that particular status. There was a wide range of functional impairments among our veterans with SCI, both in terms of the level and severity of their injuries. So we had individuals who were using power wheelchairs, manual wheelchairs, and some who could ambulate. A significant proportion of our sample had a history of traumatic brain injury. And the common mental health conditions that we see in this population, including depression and substance abuse, were represented in our sample. The bottom line is this was a very mixed sample of what we would consider the typical patients treated in the Veterans Healthcare System for spinal cord injury. Despite that wide range of impairments and different characteristics, the overall employment rate for the sample was 43.2%, which indeed is higher than was seen in the first study. I'll caution you that they're not a direct comparison, but we do feel like because of a longer implementation and better implementation were some of the factors that led to the higher employment rate. The employment duration during the study on average was about 9.5 months, although data collection discontinued at the 24-month period, so some of those individuals may have worked beyond that time. Most of our participants elected for part-time employment, though just over 16% of the sample found full-time employment per their preferences. There were a wide range of jobs that our veterans obtained. Our job development could be described by the motto, one veteran, one job. And that reflected that jobs were developed around the unique skills, needs, abilities, and desires of the veteran and the employers themselves. Some examples were jobs in the community ranging from graphic designer, police dispatcher, customer service, teachers, craftsmen, mechanics, and so on. We had some individuals who decided to pursue self-employment, either due to their own preferences for working at home or their dreams to start their own business. And some secured work in the Veterans Health Administration, in the VA, because they wanted to serve other veterans usually. Jobs in services like pharmacy, education, police, and even the executive office. We looked at quality of life changes both on objective measures and gathered data through qualitative interviews. On objective measures, persons who became employed in our study had improvements in their mobility, productivity, and their social participation on these measures. Our qualitative interviews, and there's some quotes on the screen that are representative of this, reflected that people wanted to go back to work because they were bored and didn't like sitting around. They wanted to have more interaction. Interacting with various people has been so rewarding for me, one person said. And the third quote, I think, reflects what we heard very often, which was, it's not about the money, it's about being able to contribute and give something back. So there were vast improvements of quality of life, and these were seen whether the person was working part-time or full-time. We looked at our data in terms of which services delivered by the vocational providers were most likely to lead to employment. What we found were the most effective services were those that reflected integrated services, action-oriented services, and were community-based. Services like job development, job placement, and employment supports and follow-up in the workplace. The services that were least likely to result in a competitive employment placement were more traditional models and office-based interventions, like case management and counseling and assessment. So in conclusion, IPS effectively improves employment outcomes and quality of life for persons with SCI. IPS works in a chronically unemployed population of persons with medical, cognitive, and mental health conditions. Persons with SCI benefit from integrated and ongoing employment services to address vocational goals as part of a complete program of lifelong medical rehabilitation care. There are some policy implications I'll note. Broadly speaking, I think it's wise to address employment early and, I would say, often in rehabilitation, and certainly to foster connections between vocational providers and healthcare teams. In the Veterans Health Administration, policy now supports integrated vocational services for veterans with mental and/or physical impairments, prioritizing evidence-informed employment services and community-based competitive employment. And the VA is making strides to recognize and make improvements in their partnerships with the community to support these goals. There are some references included in this presentation. I certainly would like to acknowledge a vast array of talented and dedicated professionals that contributed to this body of work, and I'm delighted that you'll get to hear from two of these individuals that I've had the pleasure to work with. And so at this time, I'd like to turn it over to Sean Smith.
Thank you, Dr. Artemanelli. So my part of the presentation, we're going to be evaluating the unique aspects of providing the individual placement and support model with spinal cord injured patients. The points of reference that I'm going to be discussing is professional standards of practice in SCI rehabilitation. I'm going to discuss the individual placement and support model as it relates to spinal cord injury individuals, vocational integration aspects of SCI patients as well. I really want to hone in on some of the distinctive vocational characteristics for spinal cord injury patients as it relates to, I guess, a differentiation between them and using the IPS model with severe mental illness. I'm also going to be addressing some medical issues and complications that I've seen personally, and talk about benefits and motivation to work. So the first slide I wanted to discuss just briefly is the professional standards. Now, this is something that just came out last year, and it's the professional standards of practice for psychologists, social workers, and counselors in SCI rehabilitation. As you can probably see, I've underlined and highlighted my name, and the reason I wanted to point that out is that I'm now working, or I'm still currently working with these individuals, that we've developed practice standards for vocational rehabilitation. And the reason I feel like that's significant is that these particular standards address a couple things. First of all, It provides the vocational counselors a seat at the table. I think that's something that in the medical model, vocational counseling was almost looked at from more of a disconnected type of service, and it's actually, again, now we have a seat at the table. In these standards, they go as far as not to just define that someone needs to seek vocational rehab or vocational rehab would be nice. It goes as far as just defining that a certified rehabilitation counselor, as someone who has a CRC, should be working with the team. And more specifically, rehabilitation and professional counselors should provide the practical resources to assist individuals with return to work goals, including vocational assessments, assistive technologies, and specialized counseling skills and techniques for addressing workplace adjustments. The other thing that they do is they look at referring these individuals, as they refer to in the standards, in a timely manner. Again, the idea, as you've seen with Dr. Ottamanelli, is it's not when someone has been discharged from the hospital. It's when someone is ready to work and that motivation is there. So I want to discuss the individual placement and supports model and how it relates to working with spinal cord injury veterans. So again, as I discussed in the previous slide, vocational rehabilitation is considered an integrated component of spinal cord injury healthcare system rather than a separate service. This is something that when I was working at State Voc Rehab and I was working with individuals with spinal cord injury, again, I was looked at as a tertiary service, something that's not very integrated. Now working on the IPS model here at Houston, this is something that is an integrated part of the service. I'm someone who sits at the table. I'm someone who communicates with physicians, therapists, nurses, and we're all working to the same goal, to help individuals attain competitive employment. And this goes into another key point. The goal of IPS is competitive employment. The reason that that's significant is that the idea of looking for a sheltered workshop or a job that's created for people with disabilities is not something that we focus on. We're looking to place someone in a job just like if someone who doesn't have a disability could attain. Our goal is not to look at positions that, again, are set aside for individuals that have disabilities. People who have sustained spinal cord injuries can also succeed in competitive employment without the pre-employment training. The goal of this is that we're trying to grab the individual right when they're interested in work. One of the goals that we have is we'd like to put someone in front of an employer within the first 30 days of them being referred to us. Again, taking the ideas of, well, what are we going to do about X, Y, and Z? Well, let's just put them in the job, and then let's look at how we're going to help them succeed once they're in the job and help the medical team surround them in order to help them sustain success. And this goes into the next principle. Vocational assessment is continuous and based in the workplace. Again, we're looking at the individual in the workplace. We're assessing them, how well they're doing in the workplace. And if they have needs specific inside of the workplace, we're able to assess those, again, in a real environment. I think one of the things that's really beneficial about this is we're not sticking individuals in a false environment or a replicated workplace and saying, ooh, if this happens, what are we going to do? Let's put them in there, and if an issue or something comes up, let's try to resolve it inside the workplace. So follow-along supports. They continue for a time that fits the individual rather than terminating at a set point. I do not discharge someone after they sustain work for 30 days, 90 days, or 120 days. There's not a set time. The goal is I discharge them when the veteran, the treatment team, and I agree that the veteran no longer needs supports. And I think that's something that's unique with this model. After the veteran, again, one of the things I remember when I was working at the state is after someone has been employed for 90 days, it's okay, see ya, good luck. In this particular circumstance, we're looking at it of, okay, 90 days, where are you at? I'm doing pretty well, but I'm still running into some issues. Okay, let's continue on. Let's look to see how we can continue. So again, we're sustaining success, so we're not seeing this individual and 6 months later coming back in saying, I lost the job for something that the employment specialist or vocational counselor could have potentially intervened. Job finding and disclosure and job support is based on the client's preference. It sounds cheesy, but I tell my veterans every single time, I say, listen, imagine that we're on a ship, you're the captain and I'm the first mate. You just tell me where you're wanting to go, and I'm going to help you get there. That's the best way I can describe the client's preference. All they need to tell me is, Mr. Smith, this is where I'd like to go, and I'm just going to help them get there. I might give them some feedback and some ideas based on their preferences, but again, the whole idea behind IPS is that the veteran is guiding us along the way. We're not putting our input in to help them make that decision. We're allowing them to make that decision. Again, services are provided in the community. Again, a real interesting twist in traditional vocational rehab. I dedicate about 70 to 80% of my time in the community, meeting with veterans, meeting with employers, and meeting with other stakeholders to help my veterans attain and maintain and sustain employment. It was a difficult transition initially, but it's something once you've gotten integrated into it, I believe it really helps the success of the veteran. And again, something that Dr. Artimanelli touched upon, and just reiterating, an interdisciplinary team approach rather than parallel services. We work as a team. We all have the same goal. We're looking to help the SCI, spinal cord injury veteran or patient, help them attain whatever vocational goals they have, whatever safety goals they have. We're all working towards the same goal, and we're working as a team. Now kind of switching gears just a little bit, I wanted to discuss a little bit about the vocational integration aspects of the SCI patients. Spinal cord injury patients have a very large treatment team when you compare them to, if we go back to traditional IPS, when we're looking at it from the severe mental illness. Spinal cord injury patients, again, as you can see in my graph, we have physicians, pharmacists, psychologists, nurses, physical therapists, occupational therapists, social workers. I can go on and talk about nutritionists and wound care specialists and respiratory therapists. The reason I mention this is I really believe that individuals that work in this capacity need to go a little bit above and beyond and get a general understanding of everyone's discipline. And again, it's not having a very in-depth understanding, but enough to where if you're going into a note and reading it, you'll have a pretty general understanding of what that particular discipline is talking about. I really believe that helps to be more efficient and effective and ultimately help the veteran with their goals. We'll continue on from there. So distinctive vocational characteristics in spinal cord injury patients. Advocating and disclosure. I think this is very important, and again, I believe this is a little bit unique when we're talking about spinal cord injury veterans. If you're talking about severe mental illness, you could potentially approach an employer, discuss employment about a veteran, and not necessarily disclose anything about the veteran having a disability if it doesn't impact the essential tasks of the job. When we're talking about spinal cord injury veterans, traditionally, most of the veterans I at least work with have some type of physical impairment, whether it's they're able to walk or ambulate and they have some physical restrictions there, or they're in a power chair or wheelchair. I believe that going in front of the employer before the veteran actually meets with them and being that voice for them, the voice for advocacy, I think is beneficial. I've really seen some great results when I've been able to go to an employer, talk about all these strengths that the veteran has, and discuss how they would be an asset to the company, and then after that point in time discuss, hey, by the way, they do have some physical needs, but based on what I'm hearing from you, they really won't impact the necessary functions of the position, and or we could look at some real simple accommodations that may be able to assist the veteran in some capacity. So that's one piece I believe is important and again unique to spinal cord injury. Next piece would be transportation. Transportation again is unique when we're talking about individuals who sustain spinal cord injury. The reason I state that is that again individuals who may have SMI can typically jump on a bus or even walk to work. when we're talking about someone that has spinal cord injury, it makes it a little bit more difficult to navigate around to identify what types of transportation may be needed in the community. So again, it's just something that you need to discuss with your treatment team and have some ideas. That's one of the things I think I talk about with the veteran during our initial meeting. What do you want to do is typically the first question. The second question is, hey, how do you plan to get there? So again, very important. Next piece is work at home. Again, if that transportation piece becomes such a barrier that we're not able to identify that, or the veteran is really in a place, it may be personal or it may be medical in nature, they really want to focus on doing something at home, we'll explore work at home options. These are something that I really like to fall back on and not make my primary. Again, I think the goal of working is that community reintegration. However, this is something we've explored. It's something that I have been able to find some success with some veterans that have found it to be, if not just as rewarding, maybe a little bit less than being able to go out into the community because they're able to, again, help people while at home, doing something that's meaningful to them, and be able to fulfill that vocational goal that they have. Next comes assistive technology, and again, I really feel like this is an important aspect when we're talking about spinal cord injury veterans, and the reason I mention that is that assistive technology is something that is a good idea just to have a general understanding when you're going to a workplace, you're in a home, you're accessing different things. It's just a good idea to have a general understanding of what kind of technology may be needed or what type of technology is out there in order to assist the employer, again, to facilitate a smooth transition for employment. Just wanted to address a couple medical issues, again, just unique to spinal cord injury. One is going to be bowel, the other one's going to be bladder. They typically run together in some capacity. The reason I state that is that if you're talking about anyone that has a spinal cord injury right around the lumbar nerve injury, spot on the lumbar spine or above, they typically have bowel or bladder issues. It's just something, again, you need to address with your treatment team and identify if there's anything that you may be able to do to help facilitate any potential barriers. I also wanted to reference pressure ulcers. The reason that this is significant is if the veteran is aware that a pressure ulcer could potentially put them out of work for, again, months at a time, depending on the significance, it will help remind them the importance of doing pressure release and different things like that. But again, the reason I mention that is, again, something to reiterate with the veteran, because the therapist always addressed that with me. Hey, make sure they're doing the pressure release, because again, when you're changing from a home environment to a work environment, sometimes you have to help the veteran get acclimated to that environment. So just discussing those types of things with them while they're in the work environment. Another thing I just really want to briefly mention is pain and spasms, and the reason that this is significant is that sometimes when we're dealing with individuals that have pain and spasms, one of the ways that they deal with that is medications, and that's something I've had to deal with in the past in regards to taking certain medications and changing that medication regime in order to help them be the most functional and adequate at the job. So again, just something to discuss with the treatment team, but it's something that I have seen before as a benefit, just again to look at. Benefits, in all honesty, I could probably spend an hour talking about benefits, but the reason I wanted to bring it up, and I think it's something significant here, is that one of the biggest limiting factors that I've seen when working with these veterans is they don't have the knowledge necessarily about benefits that I feel is correct. Speaking with a veteran for about 5 minutes about, well, they might say I have this benefit, whether it's SSI, SSCI, a veteran's benefit service connection or a non-service connection. Again, don't want to go too much into those, but the idea is just providing them with some real light feedback that yes, you can work. If you work, this is how this is going to affect your benefits. For some veterans, and individuals with spinal cord injury in general, may see that as a barrier. I have Social Security disability insurance. I'm not able to work. Well, actually, you are able to work. Here's some general information, but again, let me discuss it a little bit more. Let me let you discuss it a little bit more thoroughly with a benefits counselor. And motivation to work. You know, motivation to work, in my opinion, no matter what the level of injury, anyone can work. Motivation does increase over time based. It does go from an increase to a decrease. But again, going back to that idea is that we grasp the individual when they are interested and ready to work or motivated to work is usually the best approach in order to help facilitate and encourage a good placement. So I'm going to turn everything over to Jenny right now and have her continue on with the presentation.
Okay, thank you so much, Sean. And I would like to now discuss with you the elements that we have found to be key to successfully implementing IPS in spinal cord injury. The 4 elements that we have found to be key are leadership buy-in and active support, effective vocational providers, vocational and clinical integration, and adequate support for the vocational providers. And we're going to look at each of these elements in depth. Starting with leadership buy-in and active support. Having program and managerial support is so important to successful implementation. And that really begins with people who are in these leadership positions understanding the IPS model, its principles, which were well outlined for you just a few moments ago by Sean, and the model's validity. So this is not simply a vocational approach, but it is a model based on empirical data, and it's been proven effective. Leadership folks who really understand that are well positioned for successful implementation. Having support for integration of care and modeling for staff. When leadership is able to do this, they see the value of having employment staff, quote, at the table with the clinical providers, and they see that that makes a real difference. Participating in the collaborative efforts, establishing interdisciplinary teams that include employment, and just emphasizing from their leadership position on down that this is the way of doing business around here. That can be very powerful. Identifying key staff and clinical champions who embrace the IPS model and can bring peers on board makes a big difference. Clinical champions are folks who really sort of rise up from the staff. They're the people who are spontaneously enthusiastic about IPS and who show interest in learning and in the implementation of the model. They tend to be natural leaders among their peers. They get along well with most people, and they already have established credibility. They're really the ones able to help other staff see the value of employment for people with spinal cord injury. Resources like space on the spinal cord injury unit for vocational providers, laptops and cell phones to make working in the community easier and safer are important to ensure that the vocational providers can do their jobs. And we've discovered that leadership has a lot to do with whether these critical resources will be made available. Liaison with facility leadership to educate those who are in policy-making positions about the value of IPS in spinal cord injury. In our work, following each program monitoring visit that occurred, we would sit down with program and managerial leaders alongside facility leadership to educate everyone and debrief everyone on how things were going, to talk about veteran experiences with employment, and to make recommendations for quality improvement. And we found that keeping facility leadership in the loop in this way about how IPS was effective in spinal cord injury really helped with their support of the program. And in some cases, it contributed to approval for permanent staff positions to be created later. Now, I've been really referencing leadership support within VA as far as our experience was concerned, but we also found during our experience that having leadership approval from those who were in positions with our state voc rehab office really helped a lot as well. Nurturing those relationships and including them in our process. This enabled cross-organization partnerships, which really streamlined services for the veterans. We found that, for example, when state voc rehab staff were permitted to be regularly on site at VA to work collaboratively with our vocational providers and veterans, this made the processes run a lot more smoothly. There was a mutual understanding about enrollment criteria and about how to best navigate intakes. Leadership approval for VR staff to accept IPS assessment information and employment plans also helped to move our cases along a lot more smoothly. Another key element to successful implementation is having effective vocational providers in place. So over the 10 years of implementing IPS and spinal cord injury in VA, we learned about the characteristics of employment specialists that seem to lead to the greatest success. And those characteristics included a positive attitude and high personal and professional expectations for productivity. They included an ability to sell the job seekers and based on a true belief in the job seekers' abilities and the contributions that they could make to a workplace. Having connections in the community and comfort in making and maintaining those connections was also an important characteristic. An ability to pull together whomever was identified as an important support to the job seeker. And this could mean pulling folks from the veteran's personal life or from their treatment team, from their social circles, and certainly from their workplace. We also found that the ability to synthesize information about a job seeker in order to identify meaningful employment opportunities was critical. So being able to really understand what makes a person tick and use that information to shape an employment plan, that's a really specialized ability and extremely valuable. So we tried to look for that, and we tried to help cultivate that among our employment staff. Another characteristic is cultural competency and the ability to confidently interact with clinical peers or speak their language, and Sean referenced this a little bit. It's a matter of really understanding what the perspectives are coming from the clinical folks. And then finally, effective employment specialists in our experience are flexible, meaning they're able to modify plans that they've made according to veteran or employer priorities. They're reliable in their interactions, and that means their interactions with veterans, with employers, and with their clinical colleagues. And they can work autonomously because they're often expected to be working alone in the field. But at the same time, they need to be capable of managing their time and using it well. And sometimes they have to make solid, important decisions without being able to consult or immediately depend on other people. Well, you've really heard a lot already about the importance of vocational and clinical integration, and I think just the fact that we've all talked about it really underlines its significance. So yes, it's a key element to successful implementation. As you know, it's directly associated with one of the principles of the IPS model. The developers of the model recognized that referral to employment services led to service fragmentation, and sometimes there was not even follow-up. So having clinical and vocational providers on the same team mitigates this issue, and it emphasizes the vocational service as a treatment focus. We found that integration required a paradigm shift in the spinal cord injury arena, where although clinical services have long been integrated, the inclusion of vocational services was a novel idea, as mentioned earlier by Dr. Adamanelli. The job seeker in an integrated situation guides the process, and the job seeker has a very loud and clear voice in the development of employment and clinical treatment plans. And as I said before, the vocational provider is a participating active member of the clinical team. Employment plans are collaboratively developed, and they address all aspects of a person's life. And ideally, they're hammered out during interdisciplinary meetings where the job seeker is present and vocational providers and clinical providers are present as well. Our employment plans actually have sections to indicate who is responsible for carrying out certain action steps so that whomever is best suited to address a certain aspect of a person's life, they're held accountable. With integrated care, ideally you see mutual learning happening between the clinical and vocational folks, and you see relationships between them develop. And this really leads to more efficient and comprehensive care. And then finally, the integrated approach really makes a difference when it comes to addressing the unique needs of people with spinal cord injury who go to work. For example, when accommodations are needed, it's pretty easy to pull in an occupational therapist and have them go evaluate a workspace for modifications. Or it's easy to tap the kinesiotherapist to consult on a wheelchair cushion because an individual needs to be sitting for a longer period of time than what they've been accustomed to, and we want that to be the most comfortable and the safest situation for them. The fourth key element that we've discovered for successful implementation is adequate support for the vocational providers. So we found that the employment specialist working on an SCI unit still required the support of their vocational colleagues in order to do their best work. Support from the vocational program and regular collaboration on cases and job development was necessary. Peer consultation really went a long way to help generate ideas for jobs and to help establish new employer contacts. Most of the vocational providers that we had on our projects came out of employment services work rather than clinical settings. So they required significant education on spinal cord injury just to come up to speed with the population and to be effective. So to respond to that, we built in spinal cord injury education and staff shadowing as part of our orientation plans for vocational providers to ensure that they acquired foundational knowledge, and then we requested ad hoc education or experiences as the projects moved along to address any knowledge deficits. We found that local supervision by the vocational program manager and spinal cord injury chief was critical to ensuring that vocational providers were following program and facility protocols and policies. And that also allowed for adequate clinical consultation on cases as needed. But we also found that oversight by an implementation coordinator who attended to issues related to IPS model principles and standards was critical because, again, the IPS model is based on empirical evidence. It's very specific, and truly it requires close adherence in order to obtain those employment outcomes that everybody wants to have. Mentoring on job development was also a critical aspect of support for our vocational providers. And finally, quality improvement assessment on adherence to the principles and standards. Regular evaluation of the programs to kind of see how they were doing when we're looking at the standards of the model and being able to provide feedback and recommendations for improvement. So now that you've heard about those four key elements, I'd like to share with you an example of a program that successfully combined all four of those. And this example comes to us from the Houston VA, where Sean Smith was the employment specialist during our Promote study, and as you know, where he continues to work. So how did they successfully implement the key element of leadership buy-in and active support. What it looked like in Houston was reflected in the commitment of their spinal cord injury chief and the spinal cord injury unit psychologist who acted as their clinical champion. Together, they helped to foster a culture of employment on the unit. They were present at treatment team meetings, and they actively followed up on recommendations for quality improvement when they received them. In addition, they were active in keeping their facility leadership in the loop via the debriefs that I discussed earlier, and they also had their own separate conversations with them periodically. They would share successes with leadership to illustrate the impact of the work that they were doing. And these efforts eventually led to approval for a full-time permanent vocational position being created for the spinal cord injury service. Sean was hired actually out of his term research position into that permanent position. And for that reason, IPS continues to this day on their spinal cord injury unit. Now, I probably don't have to say too much about the effectiveness of Sean as a vocational provider there in Houston, but he was certainly key to their embracing of this element of implementation. Sean came to the study quite uniquely with a background in spinal cord injury due to having worked with a private rehabilitation hospital in Houston where he was providing employment services. So that was just a great and a very unusual mix to find. His bringing him up to speed process was much quicker than some of the other folks that we worked with. Sean had many of the characteristics that I reviewed earlier, and he developed a work style that advanced the idea of marketing veterans to employers, so that selling piece that we talked about before. He believes in his folks, and that's very evident. Sean made a deliberate effort as well to get to know his clinical colleagues early on. He proactively visited them daily, and he established his place on the unit. He also developed a strong presence with the vocational program at the VA, which is known as compensated work therapy, and this served him in terms of garnering their respect and support. As far as the element of clinical and vocational integration, Houston established a strong foundation for this during the initial 5 years of our work, SCI-VIP, and sort of got it. They just really got it in terms of including employment as a regular part of a veteran's care. Then when Sean came on board, his manner really helped him with everyone in terms of relationship development and helped them to feel comfortable with his knowledge and skills right away. Houston shows creativity in terms of considering employment options and placements with veterans, and that creativity, that latitude for being able to be creative, is supported by the chief and the clinical champion. Additionally, they've really fostered the idea of employment being a team effort. There is a lot of mutual respect among the providers there. As far as support for the vocational provider, the way that Houston really embraced this element, as I mentioned, Sean did develop a good working relationship with the compensated work therapy program, and he also had a very good relationship with the CWT manager, who was very knowledgeable about and enthusiastic about offering IPS to veterans with spinal cord injury. So the program ensured that Sean had backup for his caseload when he needed to be out. They included him in weekly vocational unit meetings, and he was given the benefit of working alongside the mentor trainer for guidance and assistance in job development. So he got that mentoring piece there. Incidentally, the mentor trainer is a regional position in VA, and it's held by somebody who's very well versed in supported employment and connected in the community. So ultimately, we were really proud of the Houston site and excited about the strong employment outcomes that they had. And we think that it was given their dedication to these 4 key elements. Hopefully, some of you attending this webcast will be interested in learning more about how IPS can be effectively implemented within a spinal cord injury population. So we've compiled several resources here for that purpose. The first is a toolkit, which our team developed last year based on our experiences and with the help of an expert panel. Now, the toolkit is designed to be used inside or outside VA, and it's currently planned for piloting at a VA location, so we're very excited about that. The link that you see here will take you to Dr. Autumanelli's professional page, and you'll find the toolkit there. The second resource, also found on Dr. Autumanelli's page, is a guide that we developed directly from our implementation research experiences. So it includes the real nuts and bolts information about bringing IPS into spinal cord injury care in VA. So it is VA specific, but it includes a lot of good information and materials in the appendices that anyone interested in this kind of work would find useful. It also includes stories about real people with spinal cord injury who went to work. And these are not only informative stories, but they're really quite powerful. And they really show the impact that employment has on people's lives. So I encourage you to take a look. And then finally, the third resource here is a journal article authored by our Promote Qualitative team and Dr. Autumanelli, examining the barriers and facilitators to implementation encountered during our work. It's very informative and enlightening, and we hope that it'll help others anticipate, mitigate, or even avoid things that could interfere with success. So I highly recommend this as well. Thank you, and that concludes my portion of the presentation.
Well, thank you so much, Jenny. Now we're going to discuss the role of practice guidelines in implementing IPS with individuals with SCI. Because one focus of our webcast series is on the potential application of a practice guideline in VR service delivery. Now, I'd like to ask our presenters to respond to 3 questions. First, what are the barriers? What are some of the benefits of having practice guidelines? Second, what type of information should such guideline include? And third, who should be involved in developing such guidelines? So I'm going to turn to Dr. Autumanelli to ask her to share her thoughts first.
Thank you. In terms of the benefits of having and using practice guidelines, I certainly feel like in the field of IPS, there's decades of research supporting the use of following standardized principles to implement the IPS model in the mental health population. And when these standardized principles are followed, we see higher fidelity to the IPS model and better treatment outcomes. In the field of spinal cord injury, using the newly developed guides and toolkits that Jenny just mentioned will help vocational rehabilitation practitioners translate and adapt this model to the special population of individuals with spinal cord injury. Additionally, we have guidance from the psychosocial rehabilitation standards that Sean mentioned at the beginning of his session on integrating vocational rehabilitation and evidence-based vocational services in spinal cord injury care. The benefit of using these guides is that they consolidate practical resources and are consistent with the research and clinical experiences implementing this model with fidelity in spinal cord injury rehab. In spinal cord injury, I think we still need to develop broader evidence base to inform the content of an actual formal clinical practice guideline. The evidence in IPS in SCI comes from the 2 VA studies discussed, and certainly further evidence or replication is needed to inform formal CPGs. I believe the next question was what type of information should be included in these guides. And I think in general, it should be the scientific and professional information that we would expect categorized by the level of evidence. We would expect to see recommendations for assessment and intervention. And I think, Jenny, you wanted to mention and highlight the importance of monitoring or evaluating programs.
Yes, I think that's also something very important. And the reason being, again, that this model is based on a set of principles and standards. And the oversight with attention given to those principles and standards really kind of helps people stay true to where they need to be. So we know that not adhering terribly closely to the model compromises potential employment outcomes. The closer a program is able to adhere to the model, the better their employment outcomes would be. So having that monitoring piece and that feedback regarding quality improvement would also be important to include.
Thank you, Jenny. It's an important consideration. And I think the final question was who should be involved in developing such guides. Certainly we would expect to see an expert panel that encompasses individuals from the multiple disciplines that deliver these types of services as outlined by both Sean and Jenny. And I would expect these individuals to be people who have demonstrated leadership in the topic area. Usually what we see in the development of guidelines is there's a core work group that's formed with input and guidance from multiple organizations to achieve consensus on a given guideline. I think the development of the professional standards of practice for psychologists, social workers, and counselors in spinal cord injury rehabilitation is a good example of this process. Sean, would you like to say a word or two about how that work group was put together and you conducted your work?
Sure. So that work group was specifically developed in order for us to update the practice standards for spinal cord injury professionals under the Academy for Spinal Cord Injury Professionals. And the work group was, again, put together so that we could assess the previous guidelines and update them. Of course, I'm a member, but we also have different members at large, psychologists, social workers, and other counselors. I would like to note that this just isn't specific to the VA. Our group has private and public hospitals all working with spinal cord injury patients. So it's a good diversity of those different disciplines all under one group in order to facilitate, again, those practice guidelines.
Thank you, Sean. Cindy, I hope this has answered your questions. It certainly has been nice about how such guidelines can help us achieve consistent best practices in the field of IPS and spinal cord injury.
Right. Thank you. Thank you so much. Thank you so much, everyone, for such an informative presentation with our audience. So I'd like to remind and encourage everyone to fill out a brief evaluation form following the link at the bottom of the slide. We will email it to all who registered. This evaluation helps us to plan our future events, and you can also ask your questions to the presenters and include your email address if you'd like them to get their answers back to you. This webcast is pre-approved for 1 hour of CRC, Continuing Education Unit credits, and your evaluation is required for you to receive your verification of completion form. Before we close, I'd like to go through a few slides at the end with information about our presenters' contact information, picture license, and also the funding source. So once again, I want to thank our presenters for their time in preparing this presentation, and my colleagues Rebecca Gaines and Ann Outlaw for their support. I'd also like to thank the National Institute on Disability, Independent Living, and Rehabilitation Research, NICLR, for providing funding for this webcast. On that final note, I'd like to conclude the webcast, and we look forward to your participation in our next event. Thank you.